Good afternoon. This is Dr. James Marion, Director of Education and Outreach at the Susan and Leonard Feinstein Inflammatory Bowel Disease Center here at Mount Sinai Medical Center in New York City. And welcome to yet again another Facebook Live via Zoom. Hopefully these are going to be in person soon, Satish. I just saw you in person from the IBD Center. And today we have a very, very important and wonderful guest. This is Dr. Satish Nagula, who is an associate professor of medicine here at Mount Sinai, Icahn School of Medicine at Mount Sinai. He's also the director of our endoscopy unit and is an associate program director for our wonderful gastroenterology fellowship. So welcome, Satish.
Thank you. Thanks for having me.
You know, what you get with Satish is sort of the wonderful trifecta and more. You get someone who is intellectually really just thrilling to listen to. He's an amazing intellect. He's got a wonderful fund of knowledge. He's an amazing endoscopist. He's a researcher. He's an educator, and he's an incredibly nice guy. Satish, it's not fair.
I'm just taking you off from your example, Jim. Come on now.
So today,
it's a pleasure. Thanks for that introduction.
I'm really happy to have you here, Satish, because I feel like we talk about these things all the time at our Friday conference, but I really wanted to give you an opportunity to discuss the sort of endoscopic management of IBD, particularly Crohn's disease, because those are the patients that you and I share most frequently. And as one of my favorite advanced endoscopist and the things that you've taught me over the years about how to manage these patients, I just wanted to make sure that this was really being shared with our patients on this broadcast. So how do you, when you think about Crohn's disease strictures, Satish, what is your approach? What goes through your mind? Show us the work. Show us your work.
Sure. It's part of it is I have the fortune of working, with great experts in IBD. So by the time you've referred us a patient with the Crohn's stricture, you've done some of the hard process or the hard thinking about this. But, the way I think about Crohn's strictures, in some patients, these are largely inflammatory. And when they're inflammatory, I sort of think of the lumen or the opening of the intestine being swollen so it's really narrowed. All that swelling, similar to the tissue swelling people get when they get a bug bite, narrows the opening of the intestine and essentially clogs the plumbing. When it's all inflammation, there's not a whole lot we can do with the endoscope. And this is where all of the incredible medical therapeutics that everyone's innovated and developed over the years has worked to really calm down that inflammation. So when it's all inflammatory, there's not a lot we can do with the scope. Sometimes we can stretch it a little bit, but it doesn't really give you any real durable response. Really where I think endoscopic approaches work is when the stricture is more fibrotic. So that inflammation has sort of settled down, that big swelling on, after a bug bite becomes more of a scab. So when you get that rigid scar tissue, that's where endoscopy and in many cases surgery can play a role. And so when I think about them, I sort of look at the scan, I take a look at any recent endoscopies, try to get a sense, does it look like it's more swollen from edema and inflammation, or does it really look like it's a scar down? Once it's gotten to scar down a little bit, I think that's where it's a mechanical problem. You fix mechanical problems with mechanical approaches. And that's where we use endoscopy to stretch open and crack that scar tissue to try to relieve symptoms.
So when you're thinking about Crohn's disease strictures, the ones you're talking about now are really more of what I would call the preoperative stricture, right? Someone who, by virtue of, inflammation not subdued over time, laying down the stricture. Do you have the same sort of view of the post-operative stricture, meaning somebody who's had either an ileocolic resection or maybe even a pouch or that type of patient? Do you view them differently? Do you approach them differently?
Yeah, I do view them differently. Part of it comes to the anatomy of what the stricture looks like. A lot of times in Crohn's strictures before surgery, many times the treatment's going to be surgical because they're often very long very complicated. When they're long strictures, endoscopy doesn't work that well. Now in the postoperative setting, now you've taken two pieces of intestine and connected them together. It's at that connection site that, sure, there could be some Crohn's activity, but there's also some loss of blood flow from the surgery and then scarring from the surgery itself. Those strictures are actually often quite amenable to dilations with endoscopy. The jury's still out a little bit. There is some evolving data that inflammation and stricturing at that surgical site might predict some Crohn's coming back. And I think with more time, we'll get a better understanding of that. But the long and the short of it is when you connect those two pieces of intestine together and that connection gets a bit narrowed down like that, that's something we can put a balloon inside, stretch that open, crack it open, and people feel better fairly quickly after that.
So, again, the innovations in the tools that we use, and at least during my career, and it's, a long one at this point, I hate to say, through the scope balloons, other types of instruments that we're able to use. A big question that comes up for these IBD patients, it's a lifelong condition. It can go on for years, decades. We often use stents for malignant strictures, with the idea that, the timeline that may not be as long, and therefore the risks and the complications of these stents are in an entirely different context, right? Do you see any future role or current role even for using any of the sort of newer stents that have been developed, really more from malignant stents, for our IBD patients?
I do. I think the first thing to think about is when we dilate the stricture, what happens? We crack that scar tissue, things are opened. But if you think about a scab on the back of your hand, if you pick at that scab, you'll get the scab off, but a little scab comes back again.
Right.
So the natural history of a stricture is you stretch it open, crack that scar tissue. It tends to narrow down again. So I tell my patients that I do these stricture dilations on that we're going to become friends. And this is going to take a few rounds to get this to stay open. Now that I've established this partnership with the patient, there are some patients where those strictures are kind of stubborn. So we crack it open and it goes down and open and down, and it just continues to go down again. It doesn't really stay open. This is where those innovations come into play. Knowing that this is sort of a cycle of sort of stricture, open, stricture again. In some patients, that stricture is so vigorous that if you put in something, let's say a stent is like a metal spring. People are used to thinking about these in the heart. Well, we use them in the GI tract all the time. They were initially designed for cancers when the cancer's closed off the intestine. In an off-label use, it's important to remember that, in an off-label use, we started to use them in benign things. So in these strictures that keep coming back, we have stents that are removable. Mm-hmm. And now instead of me blowing up a balloon for 30 seconds and cracking the scar tissue, now let's put a stent in there for 3 months. You give that intestine a chance to reshape around that stent, and then you try to pull the stent out a few months later. So think of it as a long dilation, all that time for that re-scarring to occur open.
Right.
The stents now recently been able to sort of accommodate Crohn's anatomy, going all the way up to the anastomosis. Mm-hmm. As the devices improve, I think there is some room for some patients to put these in and hopefully provide a more durable response and maybe avoid surgery for some patients.
And just, sort of along this line of, using a stent or using the dilator, some of the advanced techniques that you've, demonstrated for the esophagus and for the stomach where, needle knives are being used and you're actually doing what looks all the world to me like surgery, right? But via the endoscope, right. That sort of endoscopic surgical approach. Do you think that these might play a role as well going forward?
They might. Again, some of these other approaches are using the esophagus or for areas where it's purely scarring.
Right.
When it's purely scarring, I don't have to worry about another disease process coming into play.
Yeah.
So I think the challenge in Crohn's is trying to be as sure as you can that it's scarring and not Crohn's disease. But yes, in the right patient, you can see this web of scar tissue closing it down. Well, if it's a web of scar tissue, you could, for all the world, start to cut into that web and open that up.
Yeah.
It can be effective. It's only going to work in certain patients, but even in those small handful of patients, if we can help avoid another surgery, then it's something to try.
So, back in the day when we were using probably less refined tools to do these sort of dilations, I recall distinctly there was a fairly high complication rate with these procedures, which I've noticed with great relief now that I do these procedures myself, obviously not to the extent and degree that you do. So it appears to be far safer for the patients than it was back in the day. What should a patient or what should a doctor be thinking about after they performed one of these endoscopic dilations in an IBD patient? What are symptoms they should look for? What are red flags after this type of surgery?
Yeah, absolutely. Well, the first thing is for the physicians who are doing these procedures is to know how much to dilate. And so what I tell doctors when I train them to do this is stretch it until it looks like you did something. It's not enough to just sort of push the lining open a little bit. You want to crack the scar tissue.
Right.
Looks a little scary, sounds a little scary, but you're really trying to pick that scab. And if you haven't picked it, you haven't helped anybody.
Right.
For patients, what I tell them is I want them to really pay attention to their symptoms in the few days afterwards. After we stretch it, it's 2 steps forward, right? And then, slowly over a few weeks, it's that 1 step back. So I'll say a couple days after the procedure, you're going to get the maximal benefit out of this. And so if patients are feeling a little bloated, a little distended, a little loss of appetite because they're not emptying very well, then what I want them to really pay attention to is a day or two later, they should say, stomach feels a little softer, I feel a little more comfortable, a little less crampy. Then they can watch for when the symptoms come back.
Yeah.
I usually tell people, 2 to 4 weeks, come back and do a repeat. But everyone's different. If 3 weeks later they say they feel great, well, then we're learning about their biology. Let's stretch it out a little further. And so I really want patients to watch for that improvement and pay attention to those subtleties, because that's how they're going to know in the future that things are recurring again. The risks of bleeding or tear, they're small, less than 1%. Yeah. As long as the endoscopist is being mindful of what they're seeing and not trying to go for gold all at once.
Right.
A little bit, and then don't be afraid to come back, because you and the patient, they're friends.
Exactly. It's a relationship. Satish, what can I say? Every time I speak with you, I learn something I didn't know, and I gain a perspective which I didn't have before. So you did it again. And it is so great having you as our director of endoscopy. And you just bring so much to the role and so much to our division and so much to our unit. So thank you for joining me today and taking the time to do this. So I look forward to having you back in the future.
Well, thanks again, Jim. It's always a pleasure working with you and chatting with you. I'm happy to join again anytime in the future.
Great. So listen, this is Dr. James Marion. I've just been speaking with Dr. Satish Nagula, the Director of Endoscopy at Mount Sinai Hospital and Associate Program Director of our Fellowship, Associate Professor of Medicine, and a treasured colleague of mine. This is Dr. James Marion at the Susan Leonard Feinstein IBD Center at Mount Sinai in New York City. Please join us again next month for another episode of Facebook Live at the IBD Center. Thank you.